Presented you a wonderful presentation on a very, very tough topic, which is cataract surgery in patients with colobomas. I have a lot of particulars that I want to ask, but let me have you first sort of flesh out this topic for me.
Good afternoon. Thanks for having me here. I'm from India. Basically, I presented this paper on visual improvement with phacoemulsification in cases with coloboma, and I had a small series of 3 patients in which usually the patients were of a younger age group patients. For my average age was 40 years of age, and that is how I did my study.
So one of the points that you make is that the coloboma, that the iris defect is kind of the least of our problems. That there's an absence of zonules, and that this can certainly make surgery more difficult too. What are some of the things that you did to address this, knowing going into the surgery that you were going to have these hurdles?
Yeah, actually, when a patient of coloboma comes to us, we are in a soup. We don't know exactly how to proceed with that case because they are many times associated with comorbid conditions, such as the sclera may be involved, the involvement of the uvea, the involvement of the optic nerve head, the involvement of the macula, and particularly we don't know exactly how to do the axial length of the patient, the axial length of the patient, because many of them do have extramacular fixation because of the strabismus.
That's interesting.
So when we are checking their axial length, we have to be extra careful, because even though the patient is looking, straight, there might be extra macular fixation. So when we are doing the scan, we are not hitting the macula many times. So we have to be careful.
Yeah, that's interesting. That one of the points that I always make with my residents is that in the absence of any sort of defect in the sclera, if they're getting variable readings, the longer axial length is probably the correct one. That's certainly not the case here if the patient is fixating somewhere other than the macula. Now, once you're actually in surgery, how do you compensate? How do you prepare for things like zonular absence?
Yeah, actually, many of the patients, they don't have an absence of the zonules, but there is a weakness of the zonules. So we have to be very careful while doing our capsulorhexis and use a high density viscoelastic to flatten the anterior capsule as much as possible, so that we get a good traction when we are doing. And smaller capsulorhexis is always advisable. And we have to be careful about the defect, usually they are inferior nasal colobomas, and zonules are more weak in that area, and we have to be careful while doing our capsulorhexis in that area. So usually I plan a smaller capsulorhexis of around 4 to 4.5 millimeters, and frequently refill the anterior channel.
Are there particular sorts of cataracts for which these patients are prone?
No, they are usually they are younger age group patients, but the nucleus is soft. But in my study, I had a very hard cataract of grade 5 in one patient, and usually patients are reluctant to undergo the surgery. That is because many a times their other eyes are normal, so they, as far as possible, they delay the surgery. And at many centers, they have been told that the results of this particular surgery are not going to be as good as they thought. They think it to be. So they think it twice to undergo the surgery itself. So they are a challenge behind us.
Now, the patient's native crystalline lens is larger than the optic of the implant that you are going to be putting in, and unless the patient has an interpalpebral fissure that's particularly small, there's going to be some exposure of the IOL lens edge
Yeah.
that can cause symptoms. Do you attempt to do anything to compensate for
That's
that?
a very good question. A lot of times, means in the literature it has been reported that there is a chance of monocular diplopia
Right.
in these particular patients. But in our scenario, in our Asian populations, they are having a smaller iris, and in my particular series, they don't. I mean, they didn't seem to have that kind of a trouble. But yeah, theoretically, it is possible that the age of the optic gets exposed, and they might have monocular diplopia. So you have to be prepared to do a iris repair surgery, a kind of iridoplasty, along with the mecanal suture.
Which can be hard because it's not that you're repairing iris tissue that was there and is out of place and there's some reserve of tissue. There just isn't tissue there.
There is no. That's
Yeah.
true. So you have to do a pupilloplasty before doing the mecanal suture.
Yeah, just to make room. Well, this is really great stuff. Fortunately, these patients don't come up much.
Yeah,
When they
the
do,
incidence, by the way, the incidence is 5 in 100,000 newborns. So it's a relatively very rare condition, luckily.
Yeah, fortunately, and now I'll know a little bit more what to do. Uday, I want to thank you very much for bringing this topic to us, and of course for being so very generous with your time with us today.
Thanks a lot. Thanks for having me here.